the fact that this disease would kill me was constantly on my mind.
It's an exclusive club. Yeah. See, some of y'all ain't in it. Some of y'all probably don't even want in this club. I didn't either, but I'm in it.
It's calculated that right now worldwide we have every year 500,000 sickle cell disease patients are being born, primarily in sub-Saharan Africa.
And he walks over and he taps my stomach. He says, "Ron, you're going to have to get a kidney." That just floored me. All kind of thoughts was going through my head. I'm going to die. I'm going to be on dialysis. I didn't know what to think. I mean, I was just petrified. It's in the District of Columbia. At any given time, there's 6,000 people on dialysis. That's every single day. That's a lot of people. That is a lot of people. The real key is it grows each and every day.
Welcome to Vocal Point. I'm Anqoinette Crosby. On today's show, we're discussing sickle cell and kidney disease, two conditions that greatly impact people of color, especially those of African descent. First, sickle cell anemia, a condition that triggers episodes of severe pain, organ damage, and infection. More than 2 million Americans have the sickle cell trait, and in African Americans, the condition affects 1 in 12. Joining me to talk about the latest developments and treatments for sickle cell anemia are Dr. Griffin Rogers. He is the director of the National Institute of Diabetes and Digestive and Kidney Diseases, part of the National Institutes of Health. Dr. Rogers has also made many contributions to the development of sickle cell therapies. Dr. Patricia O'Neill is the clinical director of the Center for Sickle Cell Disease at Howard University. She is an assistant professor in the Division of Hematology and Oncology. And Gladys Onojobi is an assistant professor in the Department of Medicine at Howard University and is a principal investigator at the Center for Sickle Cell Disease. And Henry Rivera has sickle cell anemia. He suffered a recent episode and is also a client at the Center for Sickle Cell Disease. Before we go to our panel, let's listen to some stories of those who've been dealing with this illness their entire lives.
Well, my mom, she saw that there were some problems from my birth because there were times when she would try to hold me and I would cry. Growing up, I felt isolated from not only my family but also from my friends because there are times when I wanted to participate in group activities, but because of the pain, I was unable to. My first treatments for sickle cell, initially they began to work. However, as I grew older and became an adolescent, they found that the treatments no longer helped. I began to have a lot of pain crises, which is one of the side effects of sickle cell anemia, which required me to be hospitalized on numerous occasions. So what the doctors did was they began to treat me with different pain medications. They also increased my fluid intake, as well as having me to take folic acid. So it wasn't until the summer of June 2006 that I was referred to the Johns Hopkins Hospital in Baltimore. Upon doing a bone marrow biopsy, they found that because of the sickle cell, I had developed 2 forms of bone marrow cancer. In December the 29th, 2006, I received a bone marrow transplant at Johns Hopkins. My mother was my donor, and as of today, I am sickle cell free as well as cancer free.
I was born in Port of Spain, Trinidad in 1971, and at that time it was mandatory that every newborn was tested for sickle cell, so my parents found out at the time of my birth. I would get pains in my joints were the main symptoms that I had. Obviously not always being sure as to why or what would precipitate it. It took us a while to figure out how to modify my lifestyle and my activities in order to decrease how often I became ill. On moving to the U.S., I think with a more temperate climate, it really affected me in a very positive fashion. I did not fall ill anywhere as often as I was when I was in Trinidad. And I also, I think, came into my own in terms of learning a lot about my disease and about what my triggers were. So I know when to hydrate myself aggressively, when to stop in terms of physical activity, when to leave certain things alone that might be too stressful, that may be a trigger. We were recently awarded a grant from NIH for the Sickle Cell Center that specifically is going to allow us and really give us the ability to go out and study sickle cell disease in adults and adolescents in a way that would take a holistic approach at their outcomes and the determinants of those outcomes of their health. And then I think the advances in research that are taking place will help eradicate the disease. Stem cell transplantation gives us a great opportunity to decrease the number of patients that have to suffer with sickle cell. It may not be a complete home run for all, but I think it certainly could provide a great comfort for many.
I never thought I was going to be an ambassador for sickle cell, but I chose to speak up because Mr. Harvey asked me to speak up, and he said you would help a lot of people if you just opened up and spoke out about sickle cell, and I did, and boy was he right. Everybody in my family was always funny, and even when I got into a sickle cell crisis, I felt it better for me to laugh because the pain was already relevant and constant. So any break I could get from pain, which a little laugh would help every now and then, but it would end going back into pain. It'd be like, oh, but that was worth it because that period of time felt like forever. Now my health now, I'm pushing. I haven't been sick in a while. I know how to take care of myself. It's very important for me to rehydrate at the end of the day. It's very important for me to go get blood work done. It's very important for me to go exercise. It's very important for me to just keep myself well. See, I do the preventive maintenance first. That's what I like to call it, the PM. You do the preventive maintenance, and that you ride that as long as you can. And then when you do have a breakdown, hopefully you won't be broke down for long. It's amazing to me since I got involved how a lot of people say, well, you know what, man, I don't really know much about sickle cell, but they leave it at that. There's never like, I don't know much about sickle cell, and I'm gonna, find out, or I'm gonna get some research in. They just leave it at, I don't really know. When you go to the doctor, ask your doctor about, how I deal with this, or what's the first thing I need to know about keeping myself together. Because you know what, you and your sickle cell have to coexist. And mine is, we don't bother each other. I don't bother it. I don't want it bothering me. And if we do bother each other, let it not be for long. You've heard all the horror stories. Let's start putting out some success stories. And that's exactly what I would like to see happen in the sickle cell community, because I'm happy, okay? As Pharrell Williams said, I'm happy. Clap along if you feel like a room without a roof.
Well, a little levity there at the end from comedian and sickle cell ambassador Keir Jr. Spates for the Steve Harvey Morning Show. But we know this is serious business, and Henry, I'm sure that you can identify with a lot of what's being said in that video. We'll be hearing your story a little later. But first, let's talk specifics about sickle cell anemia and how it impacts the body, and what is it?
Sickle cell anemia is a genetic condition affecting approximately 70 to 100,000 people in the United States, largely from African American descent, either Africans or people of African American descent. But there's a large number of people in Central and South America, the Caribbean. Surprisingly, worldwide, the place where there's the highest prevalence of sickle cell anemia is actually in continental India. And the reason that they have such a high prevalence of it is that they not only inherit sickle cell disease, but another condition which leads to a different type of hemoglobin, fetal hemoglobin, that we all have in utero during pregnancy, that protects them against the complication. And this actually led to the understanding of development of the first effective therapy for sickle cell disease.
Okay, so sickle cell anemia is just one type of anemia, is that right?
That's absolutely right. And in patients with sickle cell disease, the primary effect of the red cells, or primary objective of the red cell, is to deliver oxygen to the tissue, pick up carbon dioxide, expel it from the lungs, and then pick up oxygen again from the lungs and repeat the cycle. Unfortunately, in people with sickle cell disease, when that oxygen is given away in the small tissues, their cells lose their ability to negotiate the small capillaries and small arteries, and it causes a clog in the system. And that is what's caused, the fundamental cause of the pain that you heard described earlier. It also injures the other tissues and eventually leads to organ damage. And because these cells get destroyed, that's what leads to the anemia.
Right. So is this genetic?
It's genetic. It's inherited. It's inherited. You need 2 copies of the sickle cell gene to have homozygous sickle cell disease. If you get 1 copy, you have sickle cell trait. And if 2 people with sickle cell trait marry or have children, there's a 1 in 4 chance that a child born from that couple will have sickle cell anemia.
And obviously there are different stages. There are milder forms of sickle cell, I'm sure, and then you can get the worst kind. So what are worst case scenarios?
Well, the worst case is, unfortunately, in young kids who develop the disease. Sickle cell weakens all the organs, but in particular in childhood, it weakens the immune system. And so these kids are very prone to infection. And unfortunately, if those infections aren't recognized early enough, the kid could suffer very severe condition, pneumonia, meningitis, even bacteria in the bloodstream, so-called bacteremia, and that can lead to death.
Okay, well, let's talk about some of the treatments, and anybody else can jump into with some of the work that you all are doing. So let's start with you in terms of treatment.
Sure. So as I indicated, these individuals around the world, largely in Saudi Arabia and India, in the Middle East, where there are high numbers of people with sickle cell disease, they tend to have mild conditions because they have another genetic defect or another genetic mutation that leads to a persistent expression of this fetal hemoglobin. And that interferes with the ability of this sickle hemoglobin from making these cells stiff. So an obvious question is there a way potentially to turn that fetal hemoglobin back on in people that don't have that genetic defect? And some 25 years ago now, our group and other groups used a drug that was commonly used for the treatment of people with certain types of pre-leukemic conditions, a drug called hydroxyurea that did just that. And after our work and after it was substantiated in other centers, this led to the NIH funding a trial called the multi-center trial of hydroxyurea, which was shown to be effective in such a large number of patients that the trial was actually stopped early. And the drug ultimately in 1995 was the first FDA-approved drug for sickle cell anemia, the first, and I should say thus far only, approved drug for the treatment of sickle cell disease.
Okay, and we're going to talk to you about some more initiatives that you're involved in as well. Dr. O'Neill, let's talk about those clinical trials and how important holding those trials are to finding a cure.
Well, first of all, the hydroxyurea trial, actually Howard University was one of the premier primary centers involved in the hydroxyurea trial that looked to see how effective this particular drug could be in adults with sickle cell disease. And those studies, the results from those studies actually generated that patients who obviously produced fetal hemoglobin and were on hydroxyurea with sickle cell disease survived longer, actually had better outcome. And then more recently, in the last 10 years, we've been also a primary site in the pediatric department of looking to see whether or not this particular drug can be initiated in children with sickle cell disease. And interestingly, that has actually shown that children who have sickle cell disease and who are on hydroxyurea have stronger immune systems, those of which is a premier issue of concern of children with sickle cell disease. And we're seeing also additional benefits that were also evident in the adult trial as well.
Okay. Henry, you found out as a child that you had sickle cell anemia.
Yeah.
So describe that a little bit, and have you been involved in any of these clinical trials?
Yeah, I started taking hydroxyurea in '99 when I was in Children's Hospital, and I did well on it. It helped a lot. But there was a point that I stopped taking it, and the pain was much worse.
Why did you stop taking it?
Because I wanted to have a baby.
Okay.
Well, me and my girlfriend was trying to have a baby, and it was hard because the pain was so severe, and I'm on it again, and I'm getting better from it, and it's been.
Are you concerned about passing along the trait to your child?
Yes, at first I was, and I used to talk with my girlfriend, and I would tell her that she needed to get tested, and she did, and she don't have the trait or nothing, so we're pretty happy that everything will be fine.
Okay,
Yeah.
and we hope it is.
Yeah, thank you.
Absolutely.
In terms of that, I was just going to say that as part of our treatment for sickle cell disease, we also make sure that we do counseling for our patients, because it's so important. Once they go through crisis, patients actually tell us that they don't want to pass this on to anybody else. And so we have a very good counseling department as well that actually counsels patients before they go into a relationship, and what options they have in terms of having to pass it on to their kids and things like that. And that really has helped.
Henry, did you do that? Did you find that it was good to talk to your doctor about that?
Yes, yeah. I would ask at the time who was my doctor, and he would take me step by step to what to do, and it helped a lot. He gave me a lot of information, and I needed that because I didn't want to bring a child to this world and suffer like I did.
So let's talk about some of that suffering. And you've had a recent episode. What is your life like? How is the quality of your life?
It's off and on, it's just a lot of care. I had to be careful with a lot of things, weather, food. I had to keep on drinking a lot of water, keep up on my meds. And I found out that working helps a lot because it keeps my mind busy. The only thing is I have to do is just stay healthy, keep drinking water, which helps a lot. It helps a lot.
Do you have other siblings, and if so, do they have sickle cell?
Yes, I have two other brothers. I'm the middle child, and only one has the trait. I have the full-blown disease, and my younger brother has the trait, and he has a daughter, and she has the trait too.
I'm sure when you hear these stories, I mean, this is the reason, all of you do the work that you do. And so are we any closer to finding a cure?
Yeah, Henry's comments are very applicable. One of the things in adults that is certainly curative, but first shown in children, is a bone marrow transplant. In fact, this year is the 20th anniversary of the first transplant for a patient with sickle cell disease. Now, the transplant wasn't given to this patient because she had sickle cell disease. It was because she had acute leukemia. But she had acute leukemia and sickle cell disease, was able to go through a transplant, and it cured both of those conditions. And subsequent studies have actually shown in pediatric population, in children, in selected cases, that a transplant, as long as you had a completely matched sibling donor, was associated with about an 85 to 90% cure of the disease. Unfortunately, only 1 in about 4 people who are eligible have a sibling donor. I think you heard mentioned that oftentimes when people have their first child with sickle cell disease, because they go through so much pain, they're reluctant to have additional children. And as Henry just mentioned, he has 2 siblings, one with sickle cell trait. On average, 1 in 4 might be a complete match for Henry. In adults, the situation is a little bit different with transplants, because over the time of their childhood and adolescence, a number of the bouts of crisis and organ damage lead them to state that the conditioning regimen, radiation and chemotherapy, makes it very difficult for patients to actually be prepared enough to go through the transplant. Recently, we've developed what's called a non-myeloablative transplant. That is a partial transplant, which is so far quite effective. We've treated so far 30 patients, and 26 of them have responded quite well.
Okay. So could you find out you have sickle cell anemia at any time? And if you do, is it better as a child? Do you have a greater chance of maybe, you know, being better treated for it?
Absolutely. And that's one of the things. And in fact, the most recent data that we have has suggested the average life expectancy for people with sickle cell disease is about 45 for men, 48 for women. That was the last time it was checked. I'm sure it's higher now. And the principal reason for that is that people recognize that the early deaths associated with sickle cell disease in childhood is due to the fact that they didn't recognize these infections early on. Now many states are required to test kids early on for not only conditions like phenylketonuria and other inborn errors, but also in sickle cell disease. Once that early diagnosis has been made, pediatricians, pediatric hematologists, and others know that to take these fevers much more seriously. And in fact, kids are started on prophylactic penicillin and given immunizations to try to ward off these infections. And that's really been a major contributor to the longer life expectancy.
As a parent, what are the symptoms should you be looking at with your child?
I'll ask my other colleagues to chime in, but obviously pain. You mean if you suspect that they have it, or?
And you may not even suspect it, but if they're playing along. In fact, I had a friend I spoke with earlier who has sickle cell. He had it as a child, 9 years old, and I said, "Well, how did your parents find out?" He said, "I was playing, but I was tired a lot. I was falling, and although they thought it was just part of me being a kid, eventually they took me to the doctor." But you know, some parents may wait a while,
Right.
so it's so is there something that they need to know to maybe kind of expedite that doctor's visit?
Yeah.
Well, I think usually you have a family history that actually points you to the fact that there's someone with sickle cell in your family. But it's amazing that even now, there's some kids that get, I don't know, for one reason or the other, don't get screened for the sickle cell disease at birth when they're supposed to have done that. So, but the point is when they get to school, also the teachers are already aware of the sickle cell crisis. So if a child is missing school a lot and is having a lot of painful crisis, and usually when they get to the hospital, that's the first thing the doctors are going to ask you as a pediatrician, that have you been tested? And you know, as Afro-Americans usually, although we now know that you don't really have to be black before you have sickle cell disease, then you get tested, and then from then on you get into care.
How did you find out, Henry?
The way my parents found out was that I got swollen. I got really swollen, and I wouldn't stop crying. And that's when my mom took me to the hospital, and she told the doctor he doesn't stop crying. And then that's when they did the test, and they found out that I had the sickle cell.
So I have to highlight what Henry said. I think the primary evidence of a child probably having sickle cell disease is dactylitis or hand-foot syndrome. If you see that your child has swollen hands and swollen feet for no reason at all, you should be suspicious for your child possibly having sickle cell disease, because
especially if you carry the trait or your spouse or
exactly.
whoever carries the trait.
Exactly.
So, sure.
Yeah.
So what are some of the initiatives that you're working on right now?
Well, some of the things that our institute is engaged in is trying to better understand what these drugs that increase fetal hemoglobin, how one could potentially come up with better agents. Just going back to the treatment for a moment, as I said, hydroxyurea is actually has really been a very important drug, but it seems to be effective in about 75 to 80% of adults. Children, as Dr. O'Neill mentioned, it seems to work much better. But not everyone enjoys that benefit, and over time there are some patients that do less well on it as a function of time. In the transplant, of course, if you have a sibling donor, that 1 in 25, you have a very high chance of being cured, either as a child or as an adult for people with the more severe disease. But again, that's going to leave out 75% of the population that don't have a donor. The real ideal goal here, and has really been the holy grail, if you would, as long as we've first understood that this was a genetic disease, that what you want to do is actually correct the genetic disease in the stem cells, in the hematopoietic stem cells. So if you could take people's stem cells, which you can readily do now without having to actually do bone marrows, and correct the defect inside of the stem cells, the sickle cell defect, or complement it with something else, you can then reinfuse, theoretically, those cells back into the patient with curative intent. And that's the type of research that we're funding now, and we're very hopeful that within the next 5 or 7 years, such a therapy might be more widely available.
Okay. A lot of good information, but we want to bring in our audience members. So please step up to the mic if you have a question or a statement. We want to hear from you, but we'd like for you to keep your comments brief so we don't run out of time. So is there anybody with a question?
Thank you for having this. I do have a daughter who's 25 who has sickle cell anemia, and much to my, not dismay, but despite my protest, has decided to move to Denver to do her graduate studies. And thinking about the altitude and the effects of the climate there, that's really concerned to me, especially looking at Ryan Clark, who played for the Steelers, who often had trouble. And I thought he had sickle cell trait in going and playing in Denver. And so part of my question is people with sickle cell trait and how potentially they may have symptoms. Is it specifically people who are more athletic, or could there be other ways to show signs of other issues just by having sickle cell trait? So that's my first question. I have another one, but just in case.
Sure.
Okay.
Well, maybe I can start off with answering that. There's been actually over the years a number of concerns expressed, particularly in college athletics, about the participation of kids with sickle cell trait in these types of events. And in fact, that was precipitated by much earlier studies in which people were not allowing people with sickle cell trait to be airline pilots or airline crew, because they thought that in flying in these unpressurized craft that this might precipitate a crisis even in people with sickle cell trait. By and large, that has been disproven. And the patients, including Ryan Clark and others, who develop this really develop it in the context of becoming severely dehydrated. Oftentimes they have a heat-related illness as well. And in just this year, for example, the American Society of Hematology has expressed very strongly its guidelines and recommendations that everyone be well hydrated and have rest periods during exertion, particularly during the summer, during football practice. This has also come up in the military, for example, in which recruits, Army recruits during basic training have suffered this problem as well. The general recommendations, though, is to treat everyone the same, make sure they remain hydrated, and and have rest periods.
My other question actually is for you, and of course others to chime in. I found that it was difficult maneuvering in school, having people understand when either she had to be out for a period of time, or even if she was in class and she had a crisis and maybe had to take OxyContin for a minute, to take control of the pain, and having other students and teachers not really understand what was going on and maybe be ostracized or actually fall behind in work and trying to advocate for herself. Or at this point, she's 25, and I kind of push her to talk to the professor. But what experiences did you have in school trying to get teachers to understand, and also in speaking with your peers in order to get some support from them as well?
When I was younger, my mom would tell my teachers my situation, but once I got older, I would hide it. I wouldn't really tell nobody about it. So when I would get sick, I would try to go home and take care of it there. In school, I would just try to play it off and not really do nothing at school. But teachers wouldn't. My situation, a lot of teachers didn't know about what was going on with me. When I was younger, yes, they knew everything, and they would take care of me as soon. If I had a crisis there, they would take me to the hospital, call my mom, and let her know what was going on.
So I'm wondering if you've ever done any outreach with colleges, campuses, or with professors or something to maybe have them be mindful of their testing practices. Or I know I've had her get in touch with Disability Services to have a plan for maybe more time on tests or a little bit time for assignments if she's been in the hospital and those things, if there's ever any outreach from the Sickle Cell Center here at Howard.
Well, we do a number of outreach programs here at the hospital, at Howard University Hospital, as well as on the college campus as well. So if you would, we can meet afterwards and we can talk about actually relaying that information to you and your daughter.
Also, we have a social worker with us in our clinic, and we actually try to encourage our patients to go for the 504 plan that they have for the disability that actually gives you extended time if you're in school, and also for your exams if you're sick, because if you're sometimes out of school for more than 20% of the time, they actually call you back. But if you have that plan in place, and we have a very good service that actually writes the letters, make sure that, and support the parents to make sure that they get what is what they should have. And this has helped quite a few of our patients to be able to stay in school.
Thank you for your question. All right, well, unfortunately, we've come to the end of the segment. After a short break, we'll return to discuss kidney disease, which affects 1 in 9 Americans. We'll say thanks again and farewell to our sickle cell panel, Henry Rivera, Dr. O'Neill, and Dr. Onojobi. And Dr. Rogers will be staying with us for the second part of our discussion. We'll be back in just a moment.
First was the lack of information. Most African Americans were not aware that we are overrepresented on transplant waiting lists. First place, 65% of those people waiting for transplants are minorities, and the majority of those are African Americans. The second is religious myths and misperceptions, concerns that in that great getting up morning when you go to the pearly gates, you don't have your organs, you won't be able to see great-grandmama in the hereafter, and forgetting that it is in giving that you receive. And when you get to the pearly gates, St. Peter is more likely to say, you had a pretty mediocre life. It was that last thing you did at the end of your life that saved some 30 lives and helped the blind see, the deaf hear again, and the lame walk again. The third is a fear that we could be used as guinea pigs. That there's a history that in the past we had been used as guinea pigs, and so that's the third obstacle which we've overcome by having people like President Obama, who's President of the United States, and Charles Drew, and many others who are in positions of power. The fourth has to do with the basic fear that if I sign a donor card and I go to the hospital,
they just might be more interested in getting my organs and tissues than with saving my life. That is no longer the case, but we have to educate and empower them to that effect. And the fifth and final reason is a concern about racism. A fear that in the past, if I leave my organs, they're only going to go to whites. And as a matter of fact, the opposite is the case here at Howard. When we started the transplant center, 80% of our donors were from whites. Now, because of MOTEP and other issues, 70% of our organs are from African Americans and other minorities. We now have gone from 15% of the donors being minorities to more than 30% of the donors being minorities when we represent 25% of the population. So we now are donating more than our share, but since we're overrepresented, we've got to do even better than that.
Thank you for staying with us for the second portion of our program. That was noted surgeon Dr. Clive Callender. He is the professor of surgery at the Howard University College of Medicine and founder of the hospital's transplant center. And he is also the creator of the Minority Organ Tissue Transplant Education Program. Dr. Callender was speaking about some of the fears African Americans have around kidney donation. Yet many on the waiting list are Black and other people of color. And 70% of transplanted organs are kidneys. We'll talk more about organ donation later in the program. But first, let's welcome our new panelists. Joining us for this segment is Dr. Jeffrey Kopp. Dr. Kopp is a senior investigator and branch chief at the National Institutes of Health. Dr. Flavia Walton is an organ donor advocate, and sitting next to her is her husband, retired Air Force Colonel Bill Walton, who has been on a has had kidney transplant for a while. And you've already met Dr. Griffin Rogers, director of the National Institute of Diabetes and Digestive and Kidney Diseases. Thanks to all of you for your participation. And as we did with our earlier discussion on sickle cell disease, we'll start off with Dr. Kopp by describing what is kidney disease and just, tell us what are some of the outlooks for the disease.
So let me begin by talking about what the normal kidney is. I have a model here. The normal most of us are born with 2 kidneys, and the kidneys grow during our development so that the kidney ends up being about the size of our fist. So this is about the size of my fist. You probably can't see it, but in the outer portion of the kidney are the filtering units called glomeruli, and their job is to filter from the blood wastes and toxins that the body needs to get rid of.
Can we hold it up just a little bit so everybody can get a good glimpse of it? Great.
And in addition, it filters salt and water and the other components that we eat in the course of the day, and then it selects which of those we need to retain and which need to be disposed of in the urine. So that's what normal kidneys do and what normal kidney function is. Kidney disease involves scarring of the kidney. Much like scarring can occur on your skin, it can occur in the kidneys through the deposition of collagen, and then over time that interferes with normal kidney function. And the big causes of chronic kidney disease in our country are diabetes, high blood pressure, I'll mention sickle cell anemia as well, and then there are some primary kidney diseases that are more common in African Americans that I think we'll be talking about in a few minutes.
So why are African Americans seem to be more predisposed to kidney disease?
Oh, that's a very important point. So the big causes are African Americans are more likely to have diabetes, more likely to have high blood pressure, and more likely to have sickle cell and particular other kidney diseases. And interestingly enough, work at NIH and elsewhere has recently identified a gene called APOL1 that explains why African Americans get more kidney disease. Much like sickle cell, individuals can inherit one variant from the father, one variant from the mother, and those 2 copies drive kidney disease. And about 5 million African Americans have 2 copies of this variant gene and are increased risk for kidney disease. Most won't get kidney disease in their lifetime, but this new understanding, developed through medical research, suggests ways that we may have new treatments in the near future.
I know someone who is overweight and had gastric bypass surgery in his 40s. Is he at risk for getting kidney disease?
He is. People who are overweight have several risks for kidney disease. One is that they're more likely to get diabetes, and then over time, typically 10 years or more of having diabetes, kidney disease becomes more common. In addition, being overweight increases the chance of having high blood pressure, which is associated with kidney disease. And finally, a larger body size puts greater stress on the kidneys. A larger body generates more metabolites, more toxins that need to be excreted, and that puts a stress and therefore accelerates any kind of kidney disease.
Colonel Walton, now how long ago was it that you found out you had kidney disease?
Oh, this was back in 2008 is when I really started to feel the impacts of failing kidneys. It led up to that over a period of time, tests, blood tests, and a constant watch over how things were going. And one thing I could add at this point is diet also has a very important impact on the kidney function. And as we go to our fast food restaurants and intake all that salt, and you heard how salt is removed in the kidney, mine unfortunately stopped doing that. And you feel the effects of that by loss of energy, difficulty even walking and putting one foot in front of the other. You're so tired and worn out. So it's no fun.
Right. You were a fighter pilot, correct?
Right.
Very cool. And thank you for your service.
Thank you.
Was it during this time that you started to notice your body feeling differently?
No, not at that point. When during the flying days, we abused our bodies quite a bit at the bar and so forth. And some were fortunate to survive all that, and some, such as I, were not quite so fortunate. But it began after I retired from the Air Force, and I didn't change my ways, so to speak, very much as I should have. So a lot of this is preventable if you take the time and learn what's going on with your body.
So your lovely wife sitting next to you was able to give you a kidney?
Right. Yep, she's my savior.
But unfortunately, it was rejected at some point.
Well, after about a year, almost a year and a half, my body just didn't like the kidney. Although the donor I met, and she was a lovely lady. And we still stay in touch.
It wasn't me. I was not the donor.
Okay.
We were part of a paired exchange,
I see.
and which is now kind of the becoming the way to do and to reduce the numbers of people on the waiting list. But we were not compatible.
I see.
As far as our blood types were
Right,
concerned.
right.
So in order for him to get a kidney, I donated one to someone else in the paired exchange so that he could get one. So unfortunately, he didn't get mine. He didn't reject me.
Of course not. Why would he? So, Dr. Kopp, how often does this happen?
How often does somebody reject a kidney? Fortunately, it's becoming less and less common. Through medical research, sponsored in part by NIH, there are better and better rejection medicines that prevent this sort of thing. I can't give you a precise number, but I suspect it's a relatively small minority of kidneys that reject in the first 5 years. I think you just had a bit of bad luck.
Right.
And often people who have problems with their first transplant will do very well with their second transplant.
So you're now on dialysis. Talk about that a little bit, and if you were able to obtain another transplant, would you go through the process again?
Well, I'm still debating a second transplant at this point. Meanwhile, dialysis has been the way of life now, and I don't live without it, is the bottom line. So you get into a kind of a groove, and mine is Monday, Wednesday, and Friday for 3.5 hours each day, getting my blood cleaned, as we call it, and getting ready to go about my business until the next day comes around and I do it again. And meanwhile, I'm watching with her guidance and help my diet and my food intake and trying to reduce the amount of toxins that I put in, because I'm going to have to take them out anyway. So it's a constant, ongoing process. I follow the rules sometimes, and sometimes I bend a rule on dieting and food. But the bottom line is dialysis is not for wimps. There's a lot of work involved, and you've got to do it.
Maybe I could jump in and say there are two kinds of dialysis. You're on hemodialysis, where you either go to a center or sometimes in your home have your blood removed for a period of 3 or 4 hours. Blood comes in, is purified, and is returned. There's also what's called peritoneal dialysis, which can be done entirely at home, in many cases overnight, every night, but allows somebody to spend their days as they choose to. So 2 options, and both are reasonably good options.
Dr. Rogers, obviously the preferred way would be a kidney transplant.
A kidney transplant. That is obviously the way that is associated with more of a normal lifestyle, as opposed to, as Colonel Walton says, being cleansed 3 times a week. We are actively supporting research to try to better the ways in which dialysis can be performed. You've heard about the 2. We are now, with NIH-sponsored research, trying to understand, rather than putting individuals, recruiting them into trials, actually recruiting very large dialysis units so that we can get our answers much more rapidly, doing what's called pragmatic trials. And currently 2 of the leading dialysis providers throughout the country have agreed to partner with us in something that's quite revolutionary, something called the time trial. And this, instead of the patient being what's called a unit of randomization, the center itself is a unit of randomization, and so that we can now treat thousands of patients as opposed to a few hundred patients at a much reduced cost. And the goal here is that since you're treating so many patients, you'll get an answer much more rapidly, which can actually change the standard of care. That's one of the things that we're doing with research. Of course, there are about somewhere between 400 and 600,000 patients who have end-stage kidney disease. And as Dr. Callender mentioned in the introduction, although African Americans make up 13% of the U.S. population, they represent 33% of the people on dialysis or who require a transplant. And I think we all agree that if you can prevent people with chronic kidney disease having to require either a transplant or a dialysis, that would be preferred.
And let's talk about prevention. What is the way to prevent?
Sure. So as Colonel Walton suggested, and there are, what we know in this country is that it's diabetes, which is the leading cause of kidney disease, and what's driving the diabetes epidemic, in a sense, in this country is actually the obesity epidemic. And so if one can interdict either at the level of stopping obesity from developing into diabetes or diabetes and developing into kidney disease, we can begin this prevention effort. The major thing is that a lot of people that have kidney disease don't know it until it's too late. In fact, as Dr. Kopp indicated, we have 2 kidneys, but actually kidney disease is called a silent disease because you can actually function all the way and be fairly normal until just 1/2 of one of those kidneys loses its function. So 3/4 of your kidney function can go away and you'll feel just fine. And so what we are trying to do is tell people early on to be tested if they have kidney disease. Why should you be tested when you're at high risk? Well, if you have a family member with kidney disease, if you have high blood pressure, if you have diabetes, if you're in certain racial and ethnic groups, as I pointed out, African Americans are at the highest risk, but Hispanics and other groups. And this is something that I think we have to really get the community involved because there are very good treatments that can slow the progression of chronic kidney disease to end-stage kidney disease. And NIH research is looking for even better ways to prevent that.
So let's talk about donation and how important it is to get the word out. What should be the call to action?
Again, that's something that we really are trying to get the message out, and I think the program here at WHUT is really an outstanding example of that, and all the great work that Dr. Callender has done with the MOTEP, Minority Organ and Tissue Donation Program. That's something that we really hope that more people take up as a project, sororities, fraternities, other groups. We are involved in a campaign, the NIH, to try to tell people about if they're at risk using two things, and if I can use a prompt.
Absolutely.
We realize that during the summer is a good time when people get together for family reunions. And so we've put together a brochure called a Family Reunion Health Guide, which really tells you how to begin a conversation about whether you're at risk and whether you should be tested. Because family reunions are really a great time for people to get together and share information about what conditions run in a particular family. The other thing that we have been putting information out on is Kidney Sundays, because we realize that increasingly people go to their places of worship where they get not only spiritual enrichment, but they can get educational enrichment as well. And so in conjunction with a number of churches around the country, as well as the Chi Eta Phi nursing sorority, we've been engaged in a process of Kidney Sundays to use these as a vehicle of getting the information out to people that could most use it.
Okay, great.
I think another very important piece too is that many people are afraid of being a donor, and there's really nothing to be afraid of. It's a very simple process. For those who are much younger than I and who still want to wear a bikini for the women, it's possible to do that. It's not a scarring kind of process. I could not milk it like I wanted to. I thought I was going to be down for a while, but in a couple of days I was up and around.
That's good to know.
So it's, and it is life-changing.
Okay.
It's a gift of life.
It sure is. All right, well, we now want to turn to our studio audience for their questions. So same rules apply as before. Step up to the mic with your questions or statement, and please be brief. So who has a question for our panel?
It's just the matter of the obesity that, you know, as you said, that it's the main cause, especially in Afro-Americans. And the question is, how would one be able to address it? I know TV shows how to diet, and you know, but it doesn't really cut into the society when you look at all the programs that are around the place. You know, the food. When you think about the food that Afro-Americans eat, it's cheap. They need to be able to feed themselves first, and then to make the choice about salads. And when you think of the cost of all that, it's just so expensive. So how do we go to the community and actually give them a program that is feasible for them to participate in?
That's a great
They can't go to gym every day. I mean, so it leaves them all behind. So
great question.
There are a lot of ways that a lot of community-based organizations are addressing this issue now. And I think, again, it's very important to get the community involved, because that's really where the change happens. It's on the community level, on the individual level. So people who are really the spokespersons in the communities really have to be engaged in the process. They are the voices that will share the information and transmit all the information that people need to make the change, because it is a change individual by individual. And I think that we can't use, we have to be advocates for ourselves. We have to learn how to advocate for ourselves. We have to learn how to go to city council meetings. We need to learn how to go to our legislators. We have to know who the brokers are, the power brokers in our communities, and insist that changes are made. We are worth the change. We contribute to our communities. We spend money in our communities. We need to know where we're spending money. Those are the people we need to apply pressure on to make the changes. It's unconscionable that people should grow up in deserts where there are not the right kinds of foods, no fresh vegetables, etc. But there are a lot of ways that communities are addressing this with community gardens and other very innovative kinds of programs that even children can participate in and learn at the same time. So there are ways that the community can become involved, and it's very important for community groups to do that, because we're the ones that are going to make the change.
Dr. Kopp, what are some of the diet mistakes that people make?
To build on what you just said, that high energy foods, high caloric foods and sweet foods are tasty. That's what we like to have. And probably it's best to try to have some of the low calorie foods, salads, fruits, and vegetables, and maybe try to fill up with those to the extent that you can, and minimize the total calories. It really is a simple equation, trying to reduce the calories coming in and increase the calorie expenditure through exercise.
Okay, we're going to have to leave it there, but thank you so much for all the insight. So we want to thank everyone for being here. Thanks to Dr. Rogers, Dr. Kopp, Dr. Walton, and Colonel Walton for enlightening us on kidney disease. And thanks to our studio audience for participating, and of course you at home for watching. This has been a great show, and we look forward to seeing you again. I'm Anqoinette Crosby. I'll save you a seat.